Thank you very much for the nice introduction and for the opportunity to be here today. I have no financial disclosures. I would like to start by just explaining a few concepts about the function and the structure of the kidneys. The kidneys are two small organs that they are located in the middle of our back, and they perform very important functions for our body. They remove waste products from the body in the urine by filtrating toxic components from the blood. They regulate the body's fluid balance to prevent dehydration or water retention. They release hormones that regulate our blood pressure. And they also produce an active form of vitamin D that promotes healthy bones and with decreased risk for fractures. In addition, they control the production of red blood cells. Therefore, when we have a problem with the kidneys and they don't work properly, there are several consequences for our body. And we tend to retain toxic products in the blood and in the body. We have problems with either dehydration or with fluid overload or fluid retention. Also, we tend to have high blood pressure or worsening of previous blood pressure. We have osteoporosis and increased risk for fractures, and we also can have anemia. Regarding the structure of the kidneys, it's quite complex, but I want to try to simplify it in one slide. Each kidney contains about 1 million of functioning units, and each of these units is called a nephron. And a nephron basically has two different components. On one part, the glomerulus, in plural is called glomeruli, they are called glomeruli. And a glomerulus is basically like a filtering unit. It's like a small filter with a lot of tiny blood vessels. And this glomerulus is connected to a tubule. So this is the glomeruli with a very tiny small vessels, and it follows with a tubule that is surrounded by other small vessels too. So what happens is that when the blood enters into the kidney coming from the renal artery, it ends up here in the border of the kidneys, and there is where the glomeruli are located, and the blood enters the glomerulus, is filtered, and this allows small waste products to be released with some fluid from the blood, and then it goes from the glomerulus to the tubule. And in the tubule, there are chemicals and water that are either added or removed from this filtered fluid. And this depends on the body's, on what our body needs in every time. And the result of all of this process is results in what we know by urine. And the urine goes to a larger tubule, and basically it flows from the kidney where it is formed to the urethra, and from there to the bladder, and is finally released from the body. So you have seen this slide this morning, and Dr. Warrington has focused on the large vessel vasculitis. We classify the vasculitis depending on the size of the vessel that is primarily involved. They can, as Dr. Warrington mentioned, they can be overlapped, but primarily they tend to affect vessels of certain size. And the ones that I'm going to focus on today, the ones that affect the kidneys, they basically affect the glomeruli, the small tiny vessels that they are filtering the blood. And I'm going to focus on a small vessel vasculitis because of that reason. There are two major groups of small vessel vasculitis that they can affect the kidneys. One is the immune complex small vessel vasculitis, and the other is the ANCA-associated vasculitis, and there are three major types: microscopic polyangiitis or MPA, granulomatosis with polyangiitis or GPA, and eosinophilic granulomatosis with polyangiitis or EGPA. There is also another subtype limited with ANCA, limited only to the kidneys. It's called like limited kidney vasculitis. So for the rest of my talk, as I mentioned, I will focus on the ANCA-associated vasculitis. They are the most frequent vasculitis that they affect the kidneys. So how does ANCA vasculitis affect the kidneys? Basically, by producing glomerulonephritis. The end of the word on itis, it just means inflammation. So what we mean by glomerulonephritis is inflammation of the glomeruli. So the tiny small vessels that they filter the blood get inflamed. And these tiny vessels, for some reason that we don't know really why, but they are very susceptible to attack in ANCA vasculitis by the ANCA antibodies. What happens as a result is that the blood and proteins frequently spill into the urine. We have so many glomeruli, fortunately, that we can lose a few of them without having any major problems. But if enough glomeruli are damaged, then the overall function of the kidney is decreased. And this is why we are insisting throughout the conference that awareness of disease and early diagnosis and prompt treatment is so crucial to avoid permanent damage. So in this slide, I just want to highlight what happens to the glomeruli, to the kidney. The glomeruli is basically, I like the analogy of a flower. It has like some connective tissue in the middle that we know as mesangium, and this is basically keeping together all the small petals that they are glomeruli of the flower. So in this diagram, as you can see, the wall of the small vessels that they are forming the glomeruli, they become inflamed, they swell up, and this brings a lot of inflammatory cells to the glomeruli and to the kidney, and this at the end results in scarring and areas of the kidney that they are not functioning very well, so they cannot filter the blood and they cannot do their functions they are supposed to be doing. And this is a picture of what we see in a kidney biopsy. I will show another one later with more detail, but basically we see areas of scarring, increased inflammatory cells, and inflammation of the wall of the vessels. Regarding progression, the progression is very variable. Some patients, they have a normal or very mild reduction in kidney function. Some patients have a rapid decline in kidney function with need for dialysis within days and weeks, especially they are left untreated. And this is what we call rapidly progressive glomerulonephritis. Most of the patients are somewhere in between these two extremes, and anything in between can happen. Regarding the frequency of kidney involvement in ANCA vasculitis, the MPA is estimated that 90% of patients with MPA can have some degree of kidney involvement. Like only 70%, well, at least 70% of GPA patients may have kidney involvement along the course of the disease, and it's less frequent in eGPA. Only 25% of patients seem to have kidney involvement in cases of eGPA. So from a more practical point of view, the patient can be thinking, so for me, what does it mean? What would I notice? So the patient can see that the color of the blood changes, and they can see that suddenly they have a red or tea-colored urine. Many times the color of the urine is completely normal because the blood in the urine is what we call microscopic hematuria. It means that it can only be seen under the microscope, so the urine looks normal, but there is blood there. They can also see that the urine has become foamy, and this normally happens when there is a high level of protein in the urine. They can also find that they have a new or worsening of previous high blood pressure. And when the kidney function decreases, initially, if it's normal or decreases only a little bit, the energy level can be completely normal, and they feel energy and they feel nothing really is going on. That's why it's very important to follow them in clinics and to do analysis of the blood and the urine when they can, because sometimes they don't really realize until it's later. If there is a moderate to severe kidney involvement, the symptoms of the patient can vary from feeling tired or fatigued to exhausted. And also, sometimes they have nausea, they can vomit when the toxic products in the blood, they really accumulate and they get higher levels. So how to know if the kidneys are involved? as Dr. Speck mentioned before, we normally do blood tests and urine analysis every time that the patient who has been diagnosed with ANCA vasculitis comes to our clinic. And we do that to follow the inflammatory markers to see if they have anemia or they have any signs of infection in the blood. And there are especially two tests that they are very important to monitor the kidney function. One is we measure the creatinine. The creatinine is a waste product in the blood that is normally removed by the kidneys when they are functioning properly. But when the kidney function is reduced, the creatinine level rises in the blood. And we normally see that in the blood test. Another measurement that we use is what we call glomerular filtration rate, or GFR. This is basically an estimation, it's like a calculation of the percentage of normal kidney function. We consider that when it's higher than 60%, the renal function is okay and we have a normal functioning kidney. But when it's lower than 10%, it usually means that the dialysis may be necessary. We also do urine test every time the patient comes to the clinic, and the presence of blood and protein in the urine is usually abnormal. The amount of blood and protein in the urine usually decreases when we start treatment with vasculitis. However, in some patients, as it has been mentioned before too, protein persists at a low level due to the previous damage. The previous scarring sometimes makes patients to have permanent proteinuria. So what other additional tests are useful? Apart from normal CBC and metabolic panel, we also like to check the immunology. The ANCA, either by immunofluorescence, when we differentiate between C-ANCA and P-ANCA, depending on the kind of staining that we see by this technique, or the specificities, anti-PR3 and anti-MPO ANCA, they give us very important clues for diagnosis and also for prognosis, because in general, PR3 are associated with higher rate of relapses. And also it gives, some doctors, they use them for a follow-up of clinical activity. This is a little bit in debate. There is no complete agreement in the literature, but some doctors use them to decide when to treat next, or if the patient, it can help in deciding if the patient has a relapse. We also like to do a kidney ultrasound when there is some kind of suspicion for kidney damage. And normally in ANCA vasculitis, the kidney ultrasound is completely normal. A kidney biopsy is especially important, and it is a procedure that is done by nephrology, normally in the clinic. It is performed under local anesthesia, and it reveals a characteristic pattern of inflammation when we look at the kidney biopsy under the microscope. It helps with the diagnosis and prognosis. And for prognosis, it's very important when we count how many glomerular we see and the percentage of them that they are atrophic, how much inflammation we see, give us a clue of what the response in the improvement of the renal function we can expect, because the inflammation normally responds to treatment with either immunosuppressant or prednisone, whereas when we see a lot of actually like consolidated damage or scarring, that is more difficult. It's like more like a suggestion that there may be some degree of irreversible damage because it's already permanent damage or scarring. So this is another example of what we see when we look at the kidney biopsy under the microscope. We see, these are like medical terminology, but we see segmental fibrinode necrosis in the glomeruli. Basically, this is a glomeruli, and it has some areas of the glomerular, they are developing scarring, that's what it means, and they have like crescent means like increased cellularity. So basically, we see inflammatory cells invading this area. They are not normally there. When the damage is getting more like stable or more like translating into scarring is when we see areas of necrosis or basically reversible damage. So for treatment, I'm only going to go over this very briefly because another speaker went into a lot of detail this morning. Basically, in general, we differentiate two different phases for the treatment. The first one is the induction phase. That is normally takes between 3 and 6 months, and the goal of this phase of treatment is to rapidly reduce the inflammation and prevent permanent organ damage. It's normally done by using high doses of steroids, many times IV steroids at the beginning, and then switching to high doses of oral prednisone. And we used cyclophosphamide a lot in the past, but now, as they mentioned this morning, we are favoring rituximab because of similar response or similar results, but less adverse effects, especially on the long term. Plasma exchange was used in the past, but as Dr. Specs mentioned this morning, recent data have revealed that maybe it's probably not adding anything. I think we are going to stop using. In our center, nephrologists are still using it. Basically, they say that until they see the published paper, they know it has been presented in meetings, but until they see the published results, they probably will use it in patients that they think have a life-threatening kidney involvement. So normally the second phase, the maintenance phase, classically lasts 18 months. This is very variable, and some patients need treatment for a longer time, especially if they have any signs of relapses. And so the maintenance phase, the goal is basically to prevent relapses once remission has been achieved. So we want to keep the disease quiet without giving any signs of active inflammation, just to prevent damage. And this is normally achieved by tapering the steroids that we started at very high dose at the beginning. And classically, we used azathioprine, methotrexate, CellCept in a few cases, but now we are more frequently using intermittent rituximab infusions between every 4 or 6 months. So what about renal relapses? How do we know if the patient is having a relapse of the kidney involvement? So what we usually see is like an increase in the amount of blood or in the urine, in the analysis of the urine, either in the lab or by deep stick. We also see a worsening renal function on blood tests so the creatinine goes up and the GFR goes down. As I mentioned before, fluctuations in the amount of protein in the urine are not good indicators of active disease. And they are usually related, or they can be related to chronic damage and scarring. They can also be associated with active disease, but we cannot, just because we see increased protein, we cannot think that the patient is having a relapse. Relapses are treated with the same approach as for newly diagnosed patients, and rituximab is increasingly being used to avoid repeated courses of cyclophosphamide, it has many potential adverse effects. So what about end-stage renal disease and dialysis? Approximately 20% of patients with renal vasculitis develop end-stage renal disease within few years. That is, they need dialysis or transplantation. I think these data are a little bit older. I haven't been able to find any new data, but based on what we see in clinic, I'm pretty sure that this is lower than 20% in our days. A smaller proportion of the patients require dialysis immediately. We still see that, especially when there is a delay in diagnosis. That's why we are insisting on the importance of awareness of the disease and doing an early diagnosis and start treatment as soon as possible. 60% of those that they require dialysis at the beginning, they are able to stop dialysis. Dialysis is basically a treatment that removes waste and excess fluid from the body. So they use a machine that filters the blood and the toxic products from the blood, just basically what the kidney should be doing, that they are not able to do it, at least for a while. The majority of patients with renal vasculitis do not need dialysis because treatments are effective at stopping the vasculitis process, and kidney function improves in many patients, especially when the treatment is started as soon as possible. However, some patients are left with some degree of renal dysfunction, and this is what we call CKD, or chronic kidney disease. Because the chronic kidney disease is associated with high blood pressure and risk of cardiovascular disease, because the kidneys are also producing many molecules and enzymes that they are needed to keep the blood pressure under control. The patient with chronic kidney disease often need medication for blood pressure, and it's very important to also treat other associated cardiovascular risk factors to decrease the risk for cardiovascular events. So what about our crystal ball? What are the predictors of end-stage renal disease? The risk of end-stage renal disease is largely determined by the degree of renal impairment at the time of diagnosis, and as Dr. Spex mentioned, 6 months after the diagnosis. The higher the initial creatinine level, the greater the chance of reaching end-stage disease. The worst prognosis is usually seen in patients who require dialysis soon after the diagnosis. But even those patients, as I mentioned, can potentially, and some of them, they don't need dialysis for life. The kidney biopsy pattern is also a reliable predictor of end-stage renal disease, and that's why we insist that to get a sample for biopsy is very important. So when we see like there is an increased percentage of scarring tissue that is, we think that means that there is potential for irreversible kidney impairment. Basically, the tissue that has been permanently damaged, it cannot recover the renal function. Other parts of the kidney that they are inflamed, that can recover with treatment. There are other risk factors for end-stage renal disease, and they include older age, resistance to treatment, frequent renal relapses, and also the coexistence of other diseases that they can affect the kidneys, such as diabetes or high blood pressure, that on themselves they can also affect the kidneys. So these patients probably may have a worse prognosis. None of this is 100% sure, and as I always say, we really don't have a crystal ball. It's very personalized, and it depends on every patient, but we try to have some clues. Just one slide, I'm almost at the end of the presentation, about renal transplantation. There are no consensus guidelines on renal transplantation in patients with ANCA vasculitis, and there are different practices between centers. Overall, we estimate that 70% of the transplants are still working after 10 years. Up to 15% of patients may have some symptoms of vasculitis recurrence after the kidney transplant, but not all the symptoms during a flare affect the kidney. Recurrence of vasculitis in the kidney can occur, but rarely causes loss of a transplanted kidney. And there are series that they have mentioned that 10 years after their transplant, about 8% of the kidneys of the patient will have lost their kidneys because of a recurrence of the vasculitis. So this is just a picture where I wanted to highlight that the transplanted kidney is placed a little bit lower in the retroperitoneum, in the abdomen. So just to summarize, the kidneys are highly specialized organs containing millions of small blood vessels that are constantly filtering and regulating the contents of the blood. These blood vessels are very susceptible to attack in ANCA vasculitis. Prompt diagnosis and early treatment are the most important factors to improve outcomes. We are developing new therapies, but early diagnosis and treatment is really crucial. Most patients do not reach end-stage renal disease, and for those that they do, kidney function can be supported by dialysis, and for some patients, renal transplantation is a good treatment option. Overall, outcomes continue to improve, and the development of more effective, less toxic treatments is expected to improve outcomes in the future. So, and that's it. Thank you very much for your attention. I don't know if you have any questions.
Any questions? Great. Hold on. I promise I'm coming. Hustle.
Hi, I'm a friend. I just wanted to know, do you do the same thing down in Tucson as they do up here in the Mayo Clinic, as far as following people with renal problems?
We don't do it too so. We don't follow the. I mean, I check the ANCA levels every time, the ANCA titers, because I'm curious and I think they can help with to know if the patient has a flare or not. But I think it's one more data for the diagnosis. We don't do the CD20 or CD19. I think the other day I checked with the lab, I think we can do the CD20, but basically we don't do that. We decide more based on or I decide more based on symptoms, the blood work that I do, but I don't follow the ANCA titers or the CD20. So religiously. I may change my practice, but so far.
I have a question. So the blood and the protein that shows up in the urine, the blood, I imagine, is from the blood vessels. But where does the protein come from?
The protein is normally filtered. I mean, it shouldn't be filtered when the function of the glomeruli is fine. It shouldn't go into it shouldn't filter into the urine. It's only when the glomeruli are inflamed and they are not filtering as well as they should. Some products that they shouldn't go into the urine, they go, and one of them is the protein. It's similar to microalbuminuria in diabetic patients, that basically there is a problem with the filtering of the glomeruli, and some products that they shouldn't go into the urine, they go. So the protein comes from the metabolism of the muscles, and it goes into the urine. Thank you.